right now. And just so you know, this video will be recorded and then will be released tomorrow. The idea was to make the recording and then release it, which is tomorrow, Sunday, April 11th, which will be the International Day of Maternal Health and Rights. So I'm just going to take a screenshot right now. All right, perfect. So good afternoon once again. You're welcome to one of our series, tagged Gems in Global Surgery series. So by way of introduction, I would first of all like to recognize the presence of our speaker for today, Dr. Essien Attah. He's a senior registrar in the University of Uyo Teaching Hospital, and he's very passionate. He's my teacher, so I think I should be in the best position in this in our midst to talk about him. So we're glad to have you with us, sir. Thank you for joining us.
Thank you, sir.
Okay, so today is the 10th of April 2021, and tomorrow will be April 11th, the International Day for Maternal Health and Rights. And we are glad to have Dr. Attah with us, who will be demystifying the challenges of maternal health and rights in Nigeria. So before I go on, okay, I would quickly love to, I would love to introduce some other persons that are amongst us here. First on my list is the chair of InciSion Nigeria. So we have Emenogu Uchenna Chisom with us, who is the chair of InciSion Nigeria. Emenogu Uchenna, please can you just say hi to our participants and the speaker?
Yes, hello everyone. It's quite a great pleasure to have you all here with us on this edition of Gems in Global Surgery. Thank you very much.
All right. So there are a lot of other persons that will join us probably midway, but I think we should just continue. Emenogu Uchenna, please, I would love you to, as a chair, speak on InciSion and then InciSion Nigeria. Just a quick summary of what we do and who we are. Thank you very much.
Okay, thank you very much, Nelson. I think I would love to use a slide for that for my presentation. Okay, can you all see the slide, please?
Yes.
Okay, fine. Thank you very much. So first of all, of course, you know where we are. This is InciSion, International Student Surgical Network. Okay, yes. And in InciSion Nigeria, we have a couple of former coaches, Aliyu Indajiwo and Nelson Demabasi. First of all, talking about InciSion, the vision of InciSion definitely it's centered around global surgery. And of course, we all know that about 5 billion people worldwide lack access to safe surgical care when needed. And this has resulted to about 17 million preventable deaths each year. And this is responsible for about 1/3 of the global burden of disease. Now, the question still comes in, why global surgery? Why global surgery? Annually, we have about 313 million surgical procedures which take place around the world. And yet, there is an additional 143 million interventions needed and about 2.28 million surgeons needed for us to meet and to cover this unmet need in global surgery. Now, this is where InciSion comes to play. As a matter of fact, InciSion is a non-profit organization which represents over 5,000 students, trainees, and early career physicians around the world who are very passionate about global surgery. And we work towards the common goal of access to safe, timely, and affordable surgical healthcare for all. Now, for InciSion, our work centers around 3 pillars, which comprises of advocacy, education, and research. Now, permit me to just take you through a short walk through memory lane. InciSion started as an informal group of students in 2014, and it grew to become formally established in March 2016. In 2017, we organized our first World Health Assembly side event at the 70th World Health Assembly on 24th of May 2017 in Geneva, Switzerland. Then in 2020, which was last year, we had about 5,000 members in over 80 countries and 45 fully established national working groups, which InciSion Nigeria is part of. Now, the vision of InciSion is timely access to safe surgical, anesthetic, and obstetric care for everyone, everywhere, when needed. While the mission remains to unite, to develop, and to mentor future surgeons, anesthesiologists, and obstetricians around the world. Our core values, of course, include capacity building, collaboration, diversity, education, equity, integrity, and mentorship. If you've been following the Global Surgery Fair, of course, you might have heard the term equity several times. This is also part of what we stand for as an organization. Our goals, we have about 7 goals in InciSion. The first is to advocate for timely and affordable access to safe surgery and anesthesia for everyone, everywhere, when needed. For everyone, everywhere, when needed. Number 2 is to connect students, residents, young doctors, and everyone who is interested in surgery, anesthesia, and obstetrics around the world. Number 3, our goal is to bridge the gap between students, residents, and young doctors and every other healthcare professionals. Then to raise the voices of students and residents and also their influence in improving global access to surgical and anesthesia care. Our goal also is to inform the wider public around the world about global surgery, its barriers, and possible interventions. And this is where advocacy comes to play. And also to contribute to advancing research in global surgery and to produce future generations of surgeons, anesthesiologists, and obstetricians. Now, in InciSion, this is our organogram, of course. We have our board of trustees. We have our board of advisors. We also have our, in our board of trustees and the board of advisors, we have our chairs also. Last year we had co-chairs, but this year we have just one chair. Then we have our vice president, external affairs, our VPI, our vice president, national working group, our vice president, finance, advocacy team lead, education team lead, research team lead. And under each of these teams, or as we call it, committees, we have team members in each of these committees. I think I will just have to leave. I won't speak much on this. For us here in InciSion Nigeria, we have 3 committees, otherwise 3 teams: advocacy, research, and education. So for us, our team lead for advocacy is Dr. Esther. For education, it's Dr. Ismail Gazal. And for research, Dr. Olaoluwa Adeyemo. I think that's the end. Thank you very much. No, it seems you're muted.
Okay, yeah, thank you very much, the chair, Uche Naimenogo, for that nice presentation. We're going to be moving to the interview proper today. So please, I will implore all participants to mute their mics and as we begin the interview. So again, I want to introduce Dr. Essien Attah. He's a senior registrar in University of Uyo, Teaching Hospital, Uyo, Nigeria, and he will be our speaker for today. The topic is challenges of maternal health and rights in Nigeria. So I hope you listen, get your pen and your paper and write things down. And as he's going to be talking about the challenges of maternal health and rights in Nigeria. Quickly, for those just joining us, tomorrow, April 11th, will be the International Day of Maternal Health and Rights, and we're having this interview as against tomorrow. So the video will be is being recorded and released tomorrow. Thank you for joining us. So, sir.
Okay. Thank you very much for having me.
All right. So, sir, we will actually love to know you more. Just before we bump into the topic proper for today, we want to know you more. What was your childhood like, family and early education? And then you could kind of veer into why you chose obstetrics and gynecology as your preferred specialty.
Okay. Thank you very much for having me on this interview. My childhood, I grew up in two major cities in Nigeria, which is Lagos and Kano. My earlier years were in Lagos, later years in Kano. So, and again, coming from the eastern part of Nigeria, I tend to have cosmopolitan outlook of the country as a whole, having experienced all parts of Nigeria. Even I attended various schools in Lagos. I attended Corona and Our Saviors for my primary education. And then I went to Federal Government College, Kano, for my secondary education. Then went back to Lagos for my university education at University of Lagos. Lagos is a very cosmopolitan city in Nigeria where there's a union and a mixture of all the various tribes, that you get to meet so many people from different parts of Nigeria, have a wider perspective of how the ideal situation should be in the country. In University of Lagos, I will say that that's where the inspiration to go into obstetrics and gynecology started from. You cannot stand tall as a man or as an individual if you don't stand on the shoulders of giants. My first contact with obstetrics and gynecology then, the head of department was Professor Obs&Gyn, and he was the first person to have done IVF in Africa, in Nigeria, then at a very, very young age then, and he became a professor at a very, very young age back then. And we always looked at him as a student as, wow, this is somebody that we all want to be like in future. And he happened to also run that fertility unit with Professor Gynaecology, a female professor of obstetrics and gynecology, who I can say was the main person that made me venture into obstetrics and gynecology. She took us as students and led us and mentored us so much that so many of us that were under her tutelage decided to go into obstetrics and gynecology, mainly because of her mentorship and her care and her concern for us as students back then. Also, a special mention for the chief resident then, when I was a house officer, Dr. Obioma Okori. He was somebody that took us not even as colleagues, he took us as brothers, as sisters, and put us through obstetrics and gynecology that many of us saw it as a profession that we want to go into in the future. Then even during my career as a resident doctor, I have to mention 4 very, very important professors that have shaped my career so much. Professor Moyo, who has been such a mentor and a great person to all of us that have trained under him, teaching us the basics of obstetrics and gynecology, and also teaching us the surgical aspects of it. Professor Moore, who is also a teacher of teachers. Funny enough, he also trained under both Obs&Gyn and Ogedembe, so I knew him right back even when I was a student and a house officer in Lagos. So with that mentorship that Professor Obs&Gyn and also Professor Ogedembe carried through even to him. So we are all children of those professors, and also special mention for Professor Professor Essien Attah, the art of obstetrics. There are very few professors that know the art of obstetrics like Professor Essien Attah. He is an obstetrician par excellence, and learning under him has been a great privilege. And also Professor Mbasi. One thing about Mbasi, one thing I learned from him is the boldness of a lion. Professor Mbasi can get into very difficult surgeries and he gets himself out very easily. We wonder what kind of man is he, but he makes things seem very simple that seem that in actual fact are very hard. So why I'm mentioning all this is also part of what InciSion is about, and that is mentorship for young doctors that are coming up in surgery, anesthesia, and obstetrics. You cannot go far without having mentors. You cannot go far in the profession without having mentors, without having teachers that teach you and bring you up to that level that they are. So that is why it's very, very important that even as you're choosing your career path as students, as young doctors, that you key into a person that you know is going to carry you through in your career, and you will definitely reach the pinnacle by the grace of God. So that is just what I just wish to pass across to assist those that are still having difficulty in choosing their career path. But career paths in surgery, anesthesia, and obstetrics and gynecology are quite fulfilling. And I encourage other young doctors to go into this field of endeavor. Thank you.
Thank you very much, sir. That was quite exceptional. I think what strikes me the most about your answer to that is that of mentorship, and I think that agrees very much with one of our core values, which is mentorship, linking up the young students and interested young physicians with those who we call the giants and who can show them the way. So thank you very much, sir. Without further ado, I would like to introduce my co-moderator. She's here with us. She's Effata Sisi. She's a final year medical student in Gynaecology University in Edo State, and she'll be taking the next question. Sisi, please, you have the floor. You're mute. Please unmute yourself.
Sorry, thank you very much, sir. So I would like to ask you, being an authority in the care of women, can you share some of your experiences with us? I know they will be like a book, but at least some. I'd like to hear some from you, sir.
Thank you very much for your question. What I can say is that since we're dealing with maternal care is like being at the war front. Now, let me just put it like that. Because there's a lot of challenges in forming and offering care to women in Nigeria. There are a lot of high points, and there are also a lot of low points. I'll give some few. Some high points when you see a patient that has been trying to get pregnant for 10, 15 years, and by the miracle of in vitro fertilization, that patient gets pregnant and has successful delivery of twins, of triplets, or even singletons, one child. That is when your joy as an obstetrician somehow becomes complete. You share in those families' joy. I know how many times I walk around on the street and somebody I can even hardly remember will walk up to me and even embrace me. Or I will say, who is this woman that is embracing you? The woman will say, thank you for your husband. He did so much to help me. Those are the kind of joy and happiness that money cannot buy, because you know that you're given back to humanity and there's somebody somewhere that appreciates what you've done so much. The low points, which one tries to make them as few as possible, is when you've done your utmost best, you've tried so hard to save a patient and you end up losing that patient. or lose the mother and lose the baby. Those are the low points in one's obstetric career, and we try and make them as few as possible. We try and put in our best so that these women will be able to be saved, because having children in Nigeria still remains a very high risk endeavor. Many feel that pregnancy and delivery should be just a normal process, normal physiological process. There should not be any problems with a woman coming to the hospital to have a delivery, and she should go back with her life intact and her baby intact. Fine, most times it happens that way. But in Nigeria, most times, more compared to other countries, it doesn't happen that way. Nigeria has one of the highest maternal mortality statistics in the world. What I mean by maternal mortality, the risk of a woman dying because of pregnancy is higher in Nigeria compared to other countries. And that should be a cause of bother to everybody. Fine, because of the global pandemic, people are afraid of coronavirus and all other viral diseases. I hear there's bird flu, this one, that. But the truth about it is that maternal mortality in Nigeria is a bigger problem than even coronavirus, bird flu, and it is sort of downplayed so much. Let me give you a very frightening statistic that Nigeria constitutes just 2% of the world population, but we contribute 20% of maternal mortality worldwide. That is scary. Only 2% of the world population contributing 20% of maternal mortality worldwide. That is very scary. In the United Kingdom, our colonial masters, the maternal mortality rate is per year is around between 9 women per 100,000 women that deliver. But in Nigeria, it's not like that. In Nigeria, we're talking about 814. Please get me right, 814. That is 100 times more than our colonial masters in the United Kingdom. So that means that there's a very big problem. And these are the issues that make us feel down sometimes, that despite our best efforts, despite what we are doing, maternal mortality still remains so high in Nigeria. And what are the efforts being put in place to reduce this maternal mortality? And let's not forget that for each woman that dies, about 5-6 other women have some serious injury to themselves. Some women lose their womb. Some women end up having the vaginal fistula, they pee, they can't control their pee again. So all these issues are the issues that are cause for concern, which we wish to address. Thank you very much.
Thank you very much, sir. I guess you said it all. It's true. The maternal mortality ratio is quite on the high side, especially here in Nigeria. And hopefully, we hope we are going to provide solutions or mention some strategies for us. Nelson, over to you.
All right. So thank you very much, my co-moderator. I really appreciate that detailed response. So, sir, again, tomorrow is the International Day of Maternal Health and Rights. And like you rightly said, we have the bulk of the poor indices is Nigeria is responsible for a bulk of the poor indices in maternal health and rights. If I heard you right, you said 814, which is very, very bad. So definitely there must be some factors or what we call problems that are responsible for this. Please, sir, can you highlight what are the problems that is facing Nigeria? What are the challenges facing maternal health and rights in Nigeria?
Thank you very much for that question. The challenges of Nigeria are like a hydra. They are multifaceted. And it is good that we try and simplify them as much as possible so that we understand what are the challenges, why are women dying more than in other countries in Nigeria. To simplify everything, there's a model in which we call the delay. A lot of obstetricians in Nigeria sat down and at the level of tertiary healthcare, that's the teaching hospitals and the federal medical centers, they sat down and saw that maternal mortality is very high in Nigeria, despite the fact that even we have these tertiary hospitals, even within them, the mortality is still high. So they commissioned a study to investigate and see what is the problem. And this study is called When Getting There Is Not Enough. That even when the women come, by the time they get to the hospital, they are not even able to survive. It's supposed to be when the woman gets to the tertiary hospital, all things are available to keep her alive. So by the time the woman gets there, she's already so bad that there's little they can do. So the number one reason why women die is delay. By the time the patient gets to the point of care that they can receive the help that they need, it's too late. They can't be helped. There's a way a person's body is that by the time they get, if they are so ill, by the time they get there, it's too late. There's little or nothing that can be done, even with the best that can be put in place to help and take care of the patient. So that is why addressing these delays in getting the appropriate and best help is very important. The first delay is the delay in making that decision to go to the hospital. There are a number of factors which we shall address during the course of this discussion that influence patient decision making. Decision to seek for care. The second delay is the delay in getting to the health facility. Some parts of Nigeria are not easily accessible. So like those that stay in the riverine area, they'll need a boat. Even those that live in the cities at night, do we have a taxi service, a dedicated taxi service in most major cities that they can pick up a woman in the night and take her to the hospital? Our ambulance services, how effective and efficient are they in developing countries? Even patients' perception to ambulance, I've seen patients say that ambulance is for only carrying dead bodies in where they are, when they are carrying, that ambulance are used as hearse to carry dead bodies in the cemetery, that they will not enter an ambulance. So the problem now is that delay in getting to the health facility. Even within the health facility, there are other delays. Finding the doctor, finding the nurse, paying for car, retrieving the patient's folder. Those are possible delays that could make a difference between life or death. So these are the problems. It is not that we don't have personnel, we don't have the capability to save these patients, to reduce maternal mortality. The problem is, by the time most patients get to the hospital, it is too late for intervention to save them. Thank you.
Thank you very much, sir. So, Sissy, would you like to take the next question? Please unmute yourself. All right.
Thank you very much, sir. In fact, funny enough, the next question was supposed to talk about some of the delays and also mention some strategies that have been in place to prevent this maternal mortality. Like we are aware, the Safe Motherhood Initiative, the emergency obstetric care. But would you agree that these measures are being effectively used? Just as with
Okay.
women.
All right. Thank you very much. There is a very, how I put it, Nigeria has a very huge problem, and that has to do with how social, cultural, and religious influences play on health-seeking behavior. I'll give you an instance. They are, in essence, a health post, primary healthcare center in every local government in Nigeria. There are general hospitals, teaching hospitals that are strategically located in various cities so as to cater for the needs of pregnant women and women that have complications due to pregnancy. But both in the north and the south of Nigeria, there are sociocultural and religious beliefs that hamper the use of these facilities. That is also a major problem. It is one thing to say to put up a facility, but to get people to use that facility is another issue. In the south, especially in the southeast, there's a high belief, there's a high level of belief in patients having delivery in churches or at home. They believe that it is wrong for women to deliver outside in the hospital. So already that puts patient health-seeking behavior such that they do not want to go to the hospital until it is too late. And this is a problem that must be addressed. And what are the reasons for these beliefs? Some believe that it is their faith in God that will ensure that they have a normal delivery and they should not deliver in the hospital. So it is good to approach religious leaders, leaders of thought, to address those issues. Also, some believe that they prefer to go to the traditional birth attendant, that they will receive better care, they are more caring. That those in the traditional Orthodox hospital are not caring to patients, they neglect the patient, and that is why women die in the hospital. Now, there's a need to address this. The World Health Organization, even the Federal Ministry of Health, has been doing a lot of training on what is called respectful maternal care, which is in line with the goals of InciSion as well, which is that you want patients to know their rights. You want hospitals staff to enable patients to know their rights, that they have a right to have care that is free of abuse, free of neglect, and free and care that is not disrespectful and takes into cognizance their own cultural belief system as well. So that tries to address that problem of patients using the health facility, having confidence in the Orthodox health facility. That will go a long way in achieving the best for the patient. In the northern part of Nigeria, there are also issues. The issue about, especially those women that are in further, they cannot go out without their husband's permission. So a woman delivers in the house, she starts bleeding after delivery. There's nobody to take her to the hospital, and she will not even go if her husband is not around to give his permission. So these issues mean what? There needs to be education. There needs to be better communication. They need to be specially trained midwives that are able to enter into the communities to take care of these women at their point of care there, and if need be, to transfer them to a higher level of care. So the main problem we have in Nigeria as a whole is not only having the health facilities, but let patients be encouraged to use these health facilities. Let me give a very, very frightening statistic. that only 60% of Nigerian women go to the hospital for antenatal care. And out of that 60%, only 1/3 of that number will end up seeking delivery from a skilled birth attendant. That is a very, very frightening statistic, and it has not changed over time. The only thing that has changed much is most women know they should go for antenatal care. But delivery in the hospital, it has almost virtually remained stagnant. So that means that we need to address that issue of respectful maternal care. Thank you.
Thank you very much, sir. Like, I'm impressed. Now, talking on this maternal rights, I want to share an experience. There was a patient came to the hospital and she came obstructed labor. Okay, she could no longer deliver per vagina, and they said the suggestion was she go for a C-section. And then the husband comes and said, no, other women have been giving birth like the Hebrew woman. Why must my wife go through a C-section? Confused and refused to sign the consent form. What do you think? If you were an attending, as an attending right there, what do you think you would do? Because if I stand to be corrected, at least abroad in UK, for example, there is this law of autonomy. As far as she's in the mental, she has the mental capability to make the decision to give consent, she's allowed to. But here in Nigeria, we sit on either a relative or a husband. What do you have to say about that?
Okay, thank you very much. That's a very important question. I will be honest with you that I don't think there's any month, if not every week, that we are faced with this challenge. And I assure you that even here in Nigeria, we respect patients' autonomy. Patient has the right to decide for themselves. What you can just do as a doctor is to counsel them. Part of that counseling, thank God you mentioned it, you're very, very experienced. That is what we also often hear. We often hear women say they want to deliver like Hebrew women. And it's good to go reference back to that part of the Bible, which is in Exodus 1, verse 17. Many people just say we want to deliver by Hebrew women, but they don't know the circumstances of which that passage in the Bible came about. Pharaoh called the Hebrew midwives and asked them, why is it that you have not killed the male children as I directed you to kill? Now, these women answered him that before they get there, that the Hebrew women are very vigorous, that they have already delivered before they get there, carry their baby and run away. Now, in honest truth, under those circumstances, do we think those women were saying the truth? It's not true. Those midwives did not say the truth. If they told Pharaoh, no, Pharaoh, we refuse to kill our own people, because that is actually the truth. But what happened? What will happen to them if they told Pharaoh, Pharaoh, no, it's a lie. We will not kill our own people. Pharaoh will kill all of them. That is the truth. And so they told, it's obvious that what they said was a lie to make sure that they will not be killed. That is the honest truth under those circumstances. So there's nothing that there are some women that are more vigorous than others. There are women that have such deliveries that, oh, they will never have cesarean section or anything like that. No. So it needs now for us to tell women the context in which that part of the scripture was put in. Tell them the consequences. That's what we call counseling. They may not agree. Oftentimes, there may be some resistance. So we go back and still counsel them. You don't say because of what they said, no, they don't agree. You just leave them and go away and say, that's their own portion in life. If they die or not, what is my own concern? No. You still go back at periodic intervals and say, Madam, how are you? Okay. When you came with these other women. These other women have delivered. You're still here. You too consider that. Isn't it a possibility that there's something wrong, there's a problem? And as a human being has a right. A human being reflects on what is going on, what they are seeing. And that helps to change their decision, helps to change what they believe in now, so as we can achieve a good outcome. So what I would advise, because a lot of doctors going forward will meet this challenge. There's no way that you will not meet this challenge, that patients want to exercise their autonomy. Very, very free if they don't agree with what you advise. But you keep on going back to remind them of the consequences. Madam, you may lose your baby's life if you continue to delay. If you lose your baby, this is a baby you're carried for 9 months, and then after 9 months, you go home with a dead baby. Think about it. Is that what you want? Madam, please, if you don't do the cesarean section, if you don't do this surgery, you may lose your life. If you lose your life, what about your other children in the home and the house? Who is going to take care of them? You make the patient to begin to see what are the likely scenarios that can occur if they don't comply with the best advice that you give. In the end, most patients comply, but there are still some patients that will not comply, and you just have to document, allow them to sign, and respect their wishes. Thank you.
Thank you very much, sir. Over to you, Nelson.
Thank you very much for that very wonderful illustration and explanation. So so far so good. It seems like the socio-cultural factors tend to be dominating. So that leads me to my next question right now, actually. Do you think there's this power tussle between the socio-cultural factors and policy-based factors in being the most important cause of poor maternal indices in Nigeria? Because we've not, I don't think we've really touched on the policy-based factors. It seems like the socio-cultural factors is kind of supreme. In your opinion, sir, do you think it is supreme, or is there a place for the policy-based factors?
Thank you very much. Policy is very, very important. Policy cannot be downplayed in actual truth, because it is the policy that gives it's like the petrol that runs the engine. However, the social-cultural factors are the human beings that drive the car. So the policy is the car itself, the petrol you put inside the car. The health or the petrol you put inside the car is the policy. The car itself is the health facility, but the human beings inside are the social-cultural and religious issues. So you cannot divorce any of them if you want to get from one location to the other. The policies too have a very huge influence on maternal rights in Nigeria. In a lot of advanced and in the developed world, maternal care, antenatal care is covered by health insurance and is seen as a social responsibility of the government. However, in Nigeria, there is no definitive policy in place on that issue. And so what happens is that a lot of the expenditure for healthcare comes from out of pocket, meaning the patients pay for their own healthcare. And that in itself, that policy on itself discourages a lot of patients from coming to the hospital on time. They calculate and see the cost of delivering in the hospital is almost 5 or 10 times more than a patient that delivers in the house. And for those that are from a lower socioeconomic group, lower social class, that cannot afford the healthcare in the hospital, those ones will gravitate to substandard care, will gravitate to the traditional birth attendant. And it's only when there are complications set in that they go to the hospital. Government policy needs to be modified so as to give universal coverage to all pregnant women. there was a time that bills were raised that were talking that for pregnant women, it should be a right. It should not be something that, would I say, it is not something that should be denied pregnant women. That should be a right, that they should have access to the best healthcare possible. However, in resource-poor countries like Nigeria, who is going to foot the bill? What financial structures are put in place to ensure universal coverage? It is not impossible, but it needs the policymakers to draw up a sustainable policy that will address this issue. And there must be commitments to this. Nigeria has signed into the Sustainable Development Goals. Thank God that the Deputy United Nations Secretary General, the Deputy Secretary General of United Nations is in Nigeria. And she was even the head of Millennium Development Goals, which have now transited into Sustainable Development Goals, which talk about reducing maternal mortality by 7%, by about 77% per annum going forward. But we are not achieving any of this, yet we signed this agreement. So that is also about advocacy, to get the policymakers to live up to their word, live up to what they signed. It is one thing to sign a document, but implement what has been signed. We have the National Health Act that has been signed into law, which talks about certain percentages of funds that are derived from consolidated revenue should be put towards healthcare and special needs like this. Is that act being followed? So that's why advocacy groups must hold government to account, must hold policymakers to account, so that we can reverse this trend of maternal mortality in the country. Then we talk about enlightenment, going now to address the social-cultural issue. We need to change our belief system, have more faith in our health services. Also, there's a need not only for people to have faith in them, the people that are involved in the health services must also make themselves approachable. We must embrace the rights, we must know and embrace the rights of the patient. Respectful maternal care should be our watchword. And this cannot be done without training and retraining. Staff motivation is very important too. Without staff motivation, a lot of what patients feel is that the frustration of those in the orthodox medical practice, that is the patients that are on the receiving end, poor remuneration, poor conditions of service, inadequate facilities. These are enough to frustrate medical practitioners, midwives, nurses, those that work in the orthodox sector of medicine. To frustrate them, and this frustration is turned back towards the patient. So that's why training and retraining is very important. One must remember the goals of why one entered into the medical practice, which is to help humanity. And though that is very, very paramount, once one remembers that, I think there will be better, the communities will embrace the health sector, and this will help a long way in reducing maternal mortality and morbidity. But also very, very important is that we must get religious leaders and other leaders of thought must be part of this drive, part of this. Now the world has changed globally than what it was before 20, 30 years ago. 40 years ago, there was nothing like Twitter, there was nothing like Facebook, there was nothing like social media about 20, 30 odd years ago. But these are inventions now that, and they have what we call influencers. There are people that other people now, not even religious people, there are these influencers now. There are other people hold in high regard and even listen to what they even say more than even what their parents say. So it's also get these people on board so that they will now be able to pass this message across. And what is the message that we want to be passed across that is so important for women? They are the message of they should go for antenatal care once they have missed their period at least for 2 months. Once by the second missed period, the woman should go for antenatal care, very important. They should also talk about financing. Finance is very important. They should draw up a program of how to finance their antenatal care and delivery care. Also, the woman should be taught about what are the danger signs and what should prompt her to go to the hospital. And on our part as medical workers, we have to go to the communities and let them be aware of what is on offer for them. With the political will, we can reverse this trend. Thank you very much.
Thank you
very much, sir. Actually, I was going to go on to ask for the solutions to these problems you previously highlighted. But however, I think you did justice in the last response you gave us. A lot of solutions. I even lost track while I was trying to jot down some things. So thank you very much, sir. Sisi, you can go now.
Okay. Thank you very, very much, sir. Yes, the delays, addressing delays, education, I quite agree with. But I also want to say, from my observation so far, I might be wrong, I stand to be corrected. I don't know, I feel they'll seem to agree with me. But I've noticed there are more of male obstetricians in Nigeria. I may be wrong, as I said earlier. Could it be because of the socio-cultural beliefs we have here in Nigeria that the woman belongs to the kitchen, she needs to do a lot of things, get herself involved with busy work? You now think that if the reverse was the case, that's if you agree with me that there are more male obstetricians in Nigeria, do you think if the reverse is the case, there could be an improvement in maternal health care? Thank you very much.
Thank you very much. Okay, one of the reasons why you're not wrong in that regard. One of the reasons why there are a lot of male obstetricians in Nigeria is that obstetrics is one of the very tasking subspecialties. Very tasking in that sometimes we keep very odd hours. When your day starts, you don't know when your day ends. And for women to key into that, you must have a very, very understanding husband. Fine. I know so many wonderful female obstetricians. There's one that I even trained briefly on that is Professor Galadanchi when I was in Kano. She is a very, very wonderful obstetrician. I don't know where she gets her energy from, because 1 minute she's in Kano Teaching Hospital, the next minute she's in Asia Bayero Maternal and Child Hospital. Next minute you hear that she has traveled from one conference to the other. I wonder where she gets her energy from. I don't think I can do half of the things that she does. But by and large, this does not necessarily, would I in essence, affect the policy making decisions that affect women's care. Because a number of times when we have round table discussions, we even see that it's even the men that are even more passionate about issues about women. And we'll be wondering, why are the women more passionate? Why are the women more passionate about their own issues? Part of the problems we have, I think, is the nature of the society we live in. Take it or leave it, Nigeria is a male-dominated society. Even the laws of Nigeria are tailored in such a way that give greater propensity to the male gender over the female. And because of this, even our religious upbringing also puts the male at the forefront of leading such discussions and all. such charge in that area. So that sort of, in a way, puts the women at a disadvantage in airing their views. However, there are those women that tend to raise their head above what society expects of them and are great advocates for women's rights, gender equality, better healthcare for women. So those women that are in those fields, they are so prominent because they seem to be coming out of the norm, they're coming out of their shell to push for this issue. So it's not necessary that we are not pushing. We are pushing hard to see how these issues can be addressed. But would I say in Nigeria, we have one main problem that is really affecting the ability for policy to push through. And that is the issue of insecurity, the issue of insurgency. Because if you look at the health statistics in Nigeria, it's worse. What weighs us down are those areas of insecurity, those areas of insurgency. So any policy that is made, when a huge chunk of Nigeria's money is going into insecurity, fighting insurgency, buying weapons for the military, how then can healthcare come into that discussion? It is very, very difficult. And that's why our health budget appears to be reducing each year, while the military expenditure keeps on increasing every year. So one of the key policy decisions is we need to end the insecurity in Nigeria so that other sectors that are bleeding because all our money is going into insecurity, other sectors like healthcare, education can be addressed. Ideally, there should be an emergency in the healthcare sector now, but nobody will be able to declare that emergency and divert so much huge resources towards maternal healthcare when insurgency, insecurity, kidnapping, banditry, armed robbery, militancy, you name it, are putting such a huge demand on the government. Thank you.
Thank you very much.
Thank you so much, sir.
Over to you, Nelson.
Yeah, thank you. Sir, this question we're about rounding up, but
Thank you.
I would really love to, I would really love to ask you this question. This is not particularly related to what we're discussing now, but I feel like it might have some, influence, or it might have some, some kind of link to what we are discussing today about maternal health. So I've noticed this particular striking link between being in obstetrics, being an obstetrician, and then engaging in politics. I can cite many examples. Our former Minister of Health, Professor Isaac Adewale, was obstetrician. The present Minister for Commissioner for Health, rather, of Akwa Ibom State, who is my teacher, and please permit me to say, sir, and also your teacher, is an obstetrician, a great one at that. So even the chief medical director of the teaching hospital, where you are a senior registrar, is also, an obstetrician. So, sir, is there any link between, being an obstetrician and also, engaging in politics?
Okay, thank you very much. Well, not to say that there's any direct link per se, but as an obstetrician, there's one title that we always wear as well, and that is that we are advocates for women's reproductive rights, reproductive and health rights. So when you become an advocate in that nature, you end up seeing that you cannot change much by sitting by the sidelines and making noise. Because when you're an advocate, it appears as if you're just on the sidelines, making noise, shouting at government every time. The best way to change the system in the end is not from the outside, but from within. So that's why a lot of obstetricians over time they sit down and realize that, I want to change the system. I want to change what is going on now. Let me go, and you find out that the only way that you can change the system is from inside and from embracing politics. So that is why a lot of them end up doing that. So it's not to say that we go for a special political class as obstetrician. No, it is just common sense. Now, when you want to change the system and you see that you are from outside, you'll be shouting, making noise for years, and nothing is changing, then if you can't beat them, then you have to join them and see if you can change them from within. So that's one of the key explanations. There are so many of them that have gone into politics, and you are doing very, very well. Thank you very much for that question.
Thank you, sir. I think I'm happy now. I'm satisfied with the
Okay. All right.
So I don't know if any of the participants have questions. How we'll be doing it is that you unmute yourself and you ask your question. If you have question, you can just signify by in the chat, then by raising up your hand, and then I would call you to ask your question. But just before that, while you're preparing your question, I would really love to introduce someone very important. He just joined us from when we started midway, and then he has stayed up until this moment. So it is my honor to introduce the founding chair of InciSion Nigeria, in person of Dr. Aliyu Ndajiwo. He's a medical doctor in Mina Teaching Hospital, Niger State, and is with us here. Dr. Aliyu, please, can you say hi to the house? An aspiring neurosurgeon too.
Thank you, Dr. Nelson, and thank you so much, Chief Dr. Essien, for having us today and enlightening us all on your vast experience and guiding us on how perhaps we would, how perhaps the state of maternal health is here in the country. It was really eye-opening. Even though I'm an aspiring neurosurgeon, I mean, as a medical officer in this country, you cannot run away from obstetrics and gynecology. It's like, I think it's the most, as a medical doctor, literally you do more things in O&G than any other specialty, even if it's not the specialty you want. And like he said, any O&G person, doctor, feels like they're reproductive rights advocates. I myself, I feel that way just from my experience in medical school and also during house job and even being a medical officer. I feel the need, to advocate, and perhaps even within, whether it's research or by educating others or by giving opportunities to others or by involving yourself to learn skills, improve the actual state of maternal health in the country. Thank you again. Thank you very much for having us and for sharing everything. Thank you.
Thank you very much.
All right. Much appreciation to Dr. Aliyu. Thank you. Is there anybody with a question amongst our participants?
I have a question.
Okay.
A final question. Okay, sir, we've heard so much about medical legal issues in respect to practicing Obs&Gyn in UK, US especially. Are there really, do we have that here in Nigeria? And if not, why are people being sued? I just wanted to know.
Thank you very much for that question. There's one thing once you graduate as medical student and become a doctor, ideally you're supposed to be given a little book called the Code of Medical Ethics in Nigeria. That book is supposed to guide your practice. If peradventure one falls below the standard set by that book or goes foul of the standard set by that Code of Medical Ethics in Nigeria, one could face some medical legal challenge. That is the starting point. So the first thing is that code should be the one guiding principles of practice. Now, the issue of medical legal issues in Nigeria. Medical legal issues are on the uprise. Why? There's more enlightenment. Patients are beginning to know more about their rights. And unfortunately, lawyers too have seen that as an area to exploit, to get money for themselves. That's the truth. There have been recently, in the recent past, I know about almost 3 conferences held by various branches of Nigerian Bar Association focused on medical legal issues. There was even one that it said medical legal litigation and untapped resource. I can never forget. I can never forget that headline. I said, what? That they are able to say that that's a new way for them to be making money. But the truth about this is what? That people are becoming more enlightened. Lawyers too are becoming more enlightened too. That this is an area that they need to explore. And take it or leave it, there are so many pressures in Nigeria that makes one want to cut corners and fall foul of these code of ethics. So that's why I advise as much as possible the younger colleagues that please don't try and cut corners in your practice. Adhere to what is preferred by this code of medical ethics in Nigeria. And if one is not sure of what one is doing, if it's proper, always refer to a more senior colleague. That is the honest to God truth. And if one is still not sure, one may need to refer to a lawyer. You'll be very surprised how many times I've had to call a lawyer and ask, is this and this proper? How do I go about this in such situations? Even hospitals keep lawyers. I remember that almost all the major hospitals have a lawyer attached because there are some scenarios that one may not be too sure of what one is doing and may need to call upon a lawyer for legal advice in case it will go to the aspect of litigation. There are so many cases that readily comes to mind, but what I would just advise is that one should walk along the straight and narrow path, because you'll be very surprised that even as a young doctor, as a young medical student, one can be called to face a panel that is doing an inquest into one's action. So that's why, as much as possible, if one is not sure of what one is doing, please defer to a more senior colleague. Me? Thank you very much for that question.
Thank you, sir.
Thank you, sir.
I really
Okay.
Thank you, sir. Yeah. Please do have any other question? Okay. In the absence of any other question, on a final note, sir, I would just like you to, give us a very short, admonition, such like something like an advice to budding, obstetricians, medical students, and even younger ones, younger obstetricians, people who want to, follow your footsteps. So, what advice would you give them, just on a final?
Well, the number one advice that I'll give is one will need. It's so important that one has a mentor. A mentor is like one guide. Is one that takes one from where they are starting from to the end point. The mentor helps to mold your character, because it's not only about the skill and knowledge. Knowledge is what you need to go through medical school. Skill is what you need to save a patient's life. But character is what builds you to be a doctor in the end of the day. So a mentor is what put together all these three aspects of one's life and guides one to achieve the best. So knowledge, I won't talk too much about knowledge because to qualify as a doctor, you must be knowledgeable. One must be intelligent. And knowledge, you can get knowledge from the books, internet, wherever. So knowledge can easily be acquired. Skill can be acquired. Assisting, there are even so many videos on YouTube, people watch videos. There are so many simulators. Skill can be acquired with time. But the character and experience to know what is the right thing to do at every point of time, to know what specialty will fit you in your career going forward, one needs a guide, and that guide is a mentor. Most times, one may not necessarily have one mentor. So if you're sitting there thinking, I have this person I like, oh, this person does this person does that, one may not necessarily have one mentor. One may have more than one mentor to help set one's moral compass. And with that, the sky is the limit. I want to thank InciSion for inviting me. I really identify with your goals and your vision, because the truth about it is that we, the more senior ones, will not be here forever. It is you that hold the future. It's you that holds the dream of medical practice globally, worldwide, going forward. You are the future. You are the ones that are going to take medicine to the next height. You are the ones that are going to invent robotic surgery. You are the ones that are going to invent robotic anesthesia. You are the ones that are going to perfect the art of telemedicine, the art of distance surgery. A surgeon, just like a pilot, is sitting. A pilot flies a drone. He's sitting in Nebraska. He's flying a drone in Iraq. One day, surgery will get to that level. The surgeon will sit down in the United States of America and will be operating a patient through robotic surgery in Nigeria. That is possible. So what I will say is that for the upcoming generation, never, don't be jaded. Let your dreams not die out. Let not your imagination die out. Because whatever you can imagine, you can always achieve. Thank you very much.
Thank you, sir. God bless you for that uplifting. Yeah. So I would quickly like to invite the chair of the InciSion Nigeria, in person of Uchenna Emenogu, to round up this session.
Hello everyone, good evening. Thank you very much for finding out time to join us today on this session. So this is just part of our series. So I want to really appreciate the speaker. Thank you very much for finding out time to grace this event. We really appreciate what you've said so far today. And I must say that you've really said so many striking things here. And part of which struck me was when you said that as healthcare practitioners, that we need to kind of educate patients on their rights. And I so much agree with you that as doctors, as obstetricians, surgeons, and co, we need to educate our patients on their rights. And even as we educate them, we also have to respect their rights. So thank you so much. And I also appreciate when you said that we should not let our imaginations die. And you went ahead to mention that we want us to come to a point where a surgeon in America can operate on a patient here in Nigeria. And I also thought that, okay, why not having a case whereby we have surgeons in Nigeria here operating on patients in America? I believe it will happen very soon. So, sir, thank you very, very much. We really appreciate you. Also, special thanks to our moderator. Yes, special thanks to our moderators, Dr. Nelson Dimabasi. You did so marvelously well. Thank you so much. And Dr. Sisi, I find it difficult to pronounce your names. Kindly bear with me, please. I think I will have to go learn that properly. Thank you very much. And I can't feel Okay. Sorry, Cole, just thank you so much for supporting us so far. We really appreciate you. And also our participants, I can't begin to mention names here. So many came around and some have left. And we still have some who have also remained here. Thank you so much for identifying with what we do here. I can see Dr. Princess Winnerfaith, Toluwani Dowu, and Tunde Olobatoke. Thank you so much for joining us here. And may I remind us that tomorrow, which is the 11th of April, 2021, has been reserved as a day to celebrate maternal health and rights all around the world. So this event was actually to usher us into that celebration. So tomorrow we'll be sharing this video on our YouTube page and also on our Facebook page. So I want to implore us to go back and like our YouTube page, like our Facebook page, our Twitter handles, Instagram, and co. I will also appreciate getting feedbacks from you on how we can make this series better in the future. So thank you very much. Back to you, Nelson.
All right. On this note, come to the end of the interview session. Thank you so much. The chair has said a lot. Sorry, I just want to reiterate by appreciating our speaker for today, Dr. Essien Attah. You've done so marvelously well, sir. We appreciate you.
Thank you very much. Thank you. I'm very grateful.
Yeah. So bye everyone.
Bye.